All right, it's recording now.
I think
Well, I won't be able to hear the screen. Well,
this is not my computer. My computer did not wish to work. So I'm using, I did bring a backup computer, and
maybe we can take turns.
Sure.
Yeah.
Yeah. Yes. Shapes.
So that you don't have your hands cramping or something.
Good idea. That'll help.
everybody see that?
Yeah.
Yeah.
All right. It's good to see y'all out here. So, today my talk, Beyond Bilingual Parrots. Has anybody here ever felt like a bilingual parrot? Or like you're being pigeonholed into that role when you interpret? Yeah. This is part of why I wanted to do this talk, because there's a whole lot more to what we do than, garbage in, garbage out. So, my big North Star in all of this is facilitation of communication. I'm going to be referring to that so many times in this. And I think some of us know it intuitively, but I feel like there's a bit of a lack of really putting some verbal meat on the bones of this in our profession. Sometimes we come into this, we get trained up to interpret, and then all of a sudden, it's a different thing than we were trained for. So, a little bit about me. I've been an interpreter in 4 foreign languages, Spanish, Portuguese, Asian Creole, for about 15 years, a little over 15 years, around here at different sites in the Boston area. I first got my CMI certification in 2012. And before that, and this I really appreciate, I used to work in an admin role in an interpreter office, and I feel like that gave me a really good sense of what it takes to run one of these operations and respect for it. And I appreciate that work, the experience I got from that. So, I set out 5 learning objectives for this talk. So one is the difference in relationship between accuracy and good communication. They work together, there's a lot of overlap, but they're not the same thing. And I think we all have an idea of that. When you're going across language, nothing is ever exactly the same. What are the situational factors that influence the quality of communication? And understanding how both active and passive approaches impact accuracy and communication quality. So maybe you want to correct something, don't know if you should, are you stepping too far out of your role? Well, the decision to do so is the same as the decision not to do so, in that it is a decision. If you decide to remain in your conduit role, that is also a decision. So it's important to think of things that way. How to distinguish between personal bias and professional judgment. And finally, how to do all this, facilitation of communication, without straying from the essential interpreter role. So, why give this talk? For me, what motivated me was, it's a couple of things. I not only interpret, most of my job is interpreting, but at my institution, I sometimes do interpreter rounds in languages I don't speak, which means I have to use interpreters myself. This is for our patients who speak rarer languages, and we don't have an in-person on-staff interpreter who can round on them. Sometimes we go and we, see how they're doing. These are inpatients who are staying in our hospitals, and we want to see if their communication is going well, are they feeling well-oriented, is there anything that they need. And one of the things I've come across when I use interpreters sometimes, this is of course not all interpreters, is this phenomenon of what I think of as the cyborg interpreter. It's this sort of, the interpreter who's kind of like, they're translating words and stuff, but you don't feel like you're getting connection. You don't really feel like the communication is happening as optimally as it could. You feel distant, in some way. And I feel like the way I was trained, and I don't know if maybe trainings are updating, didn't really prepare me for how not to fall into this role of just sort of the robotic, garbage in, garbage out type of thing. Another thing I've noticed, even when there are interpreters who are not following the robot model, there is sometimes this pressure, I think, that we feel to be interpreters and not step out of our role. and to not take up too much space in the conversation. And that's quite admirable because we want to be there for the patient and the provider are the main actors in the consult, and we don't want to get in the way of what they're doing. But if we go too much in the direction of being passive, it leads to what I like to think of as small interpreter syndrome. And this little graphic is sort of like, it kind of personifies that a little bit, So that's the reasons I have for wanting to give this talk. A note about communication. So, communication is one of these things that it's happening all the time. I'm communicating with you right now. It's sort of this everyday thing. It's thought of as like, oh, it's every day, once you're a 5-year-old kid can communicate. But I want to kind of put this in the medical context and highlight the importance of it. Analogizing, let's say that the other providers in the profession are the vital organs. You've got the heart, the lungs, the liver, the kidneys, And the communication is happening through the blood vessels. And the blood vessels are everywhere, and so they are common, they are all over the body, they are not unique to one part of the body. However, good communication is vitally important for these vital organs to function. And the communication is, I like to think of it as the blood itself, and that the interpreters are playing the role of the blood vessels. It's just very important, and that's why facilitation of communication really is my North Star. When I'm interpreting, if I'm in trouble or I don't know what to do, how do I make communication easier? So, I would say, this is a bit of an opinion I have that may be a bit controversial. Now, one reason the interpreter is called in is to facilitate communication. And here's the controversial part. It's not to interpret everything completely and accurately. Does that mean that we shouldn't? No, that's not what I'm saying. But what I'm saying is when a provider and a patient are waiting for an interpreter to arrive, are they looking for the garbage in, garbage out experience? Or are they looking for someone who understands what they're trying to get at? Someone who can sort of be their voice in the other language. And I think we all have an intuitive sense that that's a lot more than just sort of completeness and accurateness. And as much as we can, we should be complete and accurate. But we all know also there are times when that may not be possible for reasons I'll go over later. Basically, we want to understand and be understood. So, are you all of y'all are pretty familiar with this pyramid, right? The 4 modes of the interpreter. You got the conduit on the bottom, that's the basic. They say something in one language, I say it in the other language, as much as possible hewing to the meaning and the order of the words, etc., and vice versa. And of course, there's the clarifier, something got said. What did you mean, provider, when you said you don't have to come to the appointment because it'll be virtual? Did you actually mean you can still come in, you don't have to? Or did you mean don't come in? This is a sort of a basic one that I get stuck on, because if you say, well, you don't have to come in, I've had patients who still come in, and it's like, oh, well, the doctor is not actually here. Well, what? Well, that's because the ambiguity wasn't clarified, Cultural broker is for the situations when one of the participants shares a context with you that the other participant doesn't. So the provider and you are talking about sending a prescription electronically to a pharmacy. The provider says, I'm going to send your prescription to a pharmacy electronically. And from talking to your patient, they got to this country fairly recently, or someone else gets their prescriptions, that they don't know what this means. Their idea of a prescription is, maybe that the doctor would give you a piece of paper. So the patient does not have this context that a prescription could be sent electronically to a pharmacy. This is where, that's what cultural brokering is. It's the sense of like, we're going to take this context that not everybody in the room has, and we're going to bring everybody into it. And it can work the other way around, of course, when, a provider says to a patient, would you like to do treatment A, B, or C? And the patient says, I don't know, doctor, you tell me, you're the doctor. And the doctor says, who's thinking, wants to respect patient autonomy, and you get into this kind of feedback loop. Doctor, in the patient's culture, the doctor is the expert, and the patient would think it irresponsible to take decisions that the patient does not have the amount of information you might have about it. We have culturally brokered. Right? Advocacy, when there is an unsafe situation, when somebody is in danger, when a lapse in care, something critical could happen that if you don't step in, is likely to happen. As interpreters, we're the only people with 1 foot in each context. 1 foot in each language, 1 foot in each culture. A lot of the time it's going to come down to us. I think a lot of us know this intuitively, but that's why it's here. So how do you know when to shift between these roles? And this is where I think the training sometimes don't always get quite into this. Well, these roles are available, how do you do it? My rule of thumb is use the lowest possible role at which understanding is happening. Once again, I'm facilitating communication, so I'm conduiting, just interpreting what someone says, and then into the other, and if the communication is happening, I stay there. Accurately, completely, good. Move up if you need to clarify and, and as much as possible, we do want to be in the conduit role, but here's something else that I want to talk about. The shifting of roles. I think it's important to do this quickly and fluidly, in the sense that there have been times I've heard interpreters say, the interpreter would like to ask the patient about something. And I find that to be counterproductive, especially when it's an encounter where this is going to happen multiple times. The patient is, there's difficulty communicating across the culture. I think the interpreter should have more, we should feel ourselves having more leeway to just switch, that we know, because as I'm going to point out, in many ways, we are the experts in this. We're the communicators. We're the ones who do this all day. So we shouldn't have any fear of just when we see the need for a gear change the gear, and tell the provider that you're doing it, but do it, because you are the one who is best qualified to be able to verify if communication is happening well, being facilitated, etc. All right, how many of y'all have come across this before? The interpreter should remain neutral. You raise your hands. All right. How about impartial? Neutral or impartial. These words are well-meaning words, but they get a little bit troublesome, in my opinion, at times. So when we speak about how the interpreter should remain neutral or impartial, I think there's a well-meaning reason for it. And the idea being that we stay in our role, and being in our role, the boundaries are clear. What we are able to do and what we aren't. So, we don't give advice. We don't omit or alter information. We don't favor one or another side. We don't provide opinions. We don't do the provider's work for them or the patient's work for them. We don't engage in personal relationships. And of course, don't break confidentiality. So this is a list of don'ts that are, I would call them good guidelines. I think that it's perceivable how there might be places where, there's a little bit, if your opinion is asked, for example, by a provider, is the patient speaking clearly or something like that? I think there you do have the authority to provide an opinion. But generally speaking, not to provide medical opinions about what to do. These generally are pretty good guidelines. So let's keep them off to the side here. The issue that I have is with the concept of the word neutral or impartial. I don't think it's the right word for what we're trying to get at. I think that the word balanced is a much better word, and I'll give some situations when that's the case. So let's say that, you are interpreting something into the patient's, the provider says something, and the patient understands some English. The provider says, did you take your medication this morning? Patient says, yes, in English, before you said anything. What is the impartial way to go about that? You could impose yourself and say it in the patient's language. You might decide to do that. It might be a good idea to do that because you don't know how much the patient understands. However, if this is happening again and again, how much is your imposition of the translation on the process really necessary? I think that's a judgment call. And I think that as experts in this, we, as the communicators, the people who facilitate communication all day, we have a modicum of ability to kind of judge on the fly what's going to work best here. If someone interrupts you, or more than one person speaks at once, what's neutral? Do you let them kind of keep going? Is that the neutral thing? Or do you, clarify the role of the interpreter? Excuse me, I need to finish, what was being said. I cannot do my job properly if more than one person is talking. Both of these approaches might be valid, in different cases. Neither of them feels particularly neutral to me. So, that Tangents is another thing. Maybe they're not interrupting, but you don't know when the person's going to stop talking. So when you're cutting, it's a judgment call. It's a case by case basis. If there are technical impediments as well, with the rise of video and remote communicating, this is a big deal. How many times have you've been in a place where like you're someone saying something, and it was a good, and it's like, what are you supposed to make of that? Well, how much of it did you hear? How, is the communication so bad that asking to repeat a second time is only going to make you need to ask a third time? There are judgment calls involved here, and that's where my North Star is, like, what facilitates communication? Maybe I get off the call because, the connection is bad, okay. What if the provider says, well, the connection is bad, you're our third interpreter? Well, do I stay on and I say, okay, provider, this is what I feel confident to say. I will get you the bits that I understand, and I will tell you what I don't understand. That might be the way to go. That doesn't feel particularly impartial to me. And when there's trouble hearing or speaking, this is where impartial starts to lose its luster for me. Because here, when someone is having trouble, I want to be partial to their understanding. I actually want to have a bias in favor of doing the best I can so that we understand each other. I may not succeed 100%, I probably won't. In certain cases, there may be some things that don't get through, but I want to try. And when there's important context, you don't want to stay on the sidelines for that, because that's the kind of thing that can derail a conversation when people are having different conversations. And when terms don't translate easily, same thing, similar concept, try as much as possible to bring everything in. I think everybody in, I should say. I think that that's something that it requires a bit of a gear shift in your head, out of the role of like, well, I'm just going to interpret what was there, and into the role of, I have information here that everybody needs to have in order for us to continue well. There are three other situations in which I think neutrality or impartiality is not really the best framework for these things. One of them is this. I find this is not talked about a lot. Like, providers have these 20-minute slots, and the patient has another appointment where their ride is waiting, and people just don't have time. And there's a lot to go over. And what do you do in that circumstance? What do you do if the patient says, well, we don't have a lot of time, but the patient is tangential, or the provider wants to explain a whole bunch of things? I don't think neutrality is the right way to think about this, especially considering that an interpreted encounter has twice as much verbiage in it, because everything is being uttered in the other language. When there's lack of trust, oh goodness. Oh, how many of y'all have seen how lack of trust affects a communication? Doesn't it though? Doesn't it? When a patient, the provider, you can interpret accurately and completely everything a provider says, and the patient will nod their head, because when a patient doesn't trust the provider, often they won't tell the provider, but you'll know, you'll get that feeling, something's not right here, and then the patient will come back the next week and the provider will say, why didn't you take your meds? And why didn't you follow this and that? And maybe you'll interpret that encounter where they had a perfectly good interpreter last time. It's because there was a lack of trust. And I think that we have an ethical obligation to try to repair trust. It doesn't mean we will be successful. It doesn't mean that we go overboard in it. We do need to know our limits. But I don't think that the provider who does not speak the other language, is not in the other culture, is equipped without our help to try to repair the trust. And the communication does not happen effectively when there is a lack of trust. Finally, when someone's safety is at risk, all over the United States there are mandatory reporter laws. So I don't have to go much into this, and fortunately our standards of practice do have this sort of escape vent for when there is a safety risk. We come forth and we address it. We get it addressed with the right authorities. So at the top of the slide, I just changed the word neutral to balanced. I was fooling around with some gimmicky PowerPoint stuff. I thought, oh, that's an interesting transition. So balanced is my term. Whenever someone says neutral or impartial, I say balance. That's the thing. It's when we are out of balance as interpreters, that's when things are getting a little iffy, and when we need to make adjustments to stay in balance. as people who are doing this all day long, on the phone, in person, I think we're also some of the best people to judge what balance is. We're the communication specialists. I really want to harp on this here. It's my opinion that we're co-providers. We're providers of communication. We ought to think of ourselves as providers. I've heard a lot of wonderful dialogue in the previous sessions about how we should be, our industry should be more professionalized. Our profession should be better recognized. We should have better standards. Providers and hospitals should know that, like, what we do is a profession just like any other. It's just as seminal, to the work that providers are doing, to the work that hospitals and clinics are doing. And as the specialists, we have a certain authority that we should not shrink away from. I feel very, very strongly about that. So let's talk I want to give another angle on why I believe this to be such a big deal. What are the psychological loads of the people coming into the room to have conversations, right? The patient is coming in, they've got to talk about what's going on with them. They've got to answer questions. They also have things going on in their mind. They're wondering, they're anxious. Many patients are anxious about going to the doctor. What am I going to say? What are they going to say? Do I say it this way? Do I say it that way? Oh, did they take their medicines? What medicines did they take? Did they bring a list with them? Is their health insurance up to date? That's a lot of psychological load. It's a lot. So a patient not only has to communicate, but they have to, the wheels in their head are turning, and they have to communicate. There's a kind of two things happening here. The provider is doing the same sort of multitasking in their head, right? So the provider has to understand what the patient's problems are. They have to listen. They have to ask the right questions. They often have a limited window of time within which to do this quickly and efficiently. And they have to find a way forward. When the patient leaves, if it's a successful encounter, the patient will know what's next. What's next may not be pleasant, may not be what the patient wants, but they will know what's next. And a provider is being paid to shoulder that responsibility. And the provider has to communicate it well. Now, when an interpreter comes into the room, our job is very intense. Repeating something from one language to another all day long, like everything that was said, that's intense stuff. However, we don't have any native concerns. And here's what I mean by that. In the encounter, we are not responsible for advocating for ourselves, because the encounter is not about us, so that's off the table. And we're not responsible for devising a system for the patient or some kind of way forward, so that's off the table. All we are doing is facilitating communication. We have a certain space in our heads, because we're not dealing with this other stuff, to focus in, to hone in on the communication, and to think as we're doing it, what's going on here? Okay, is understanding happening? Where could it not be happening? What's a danger here? What's a context that might pop up here, that's just not really in the other person's mind? We can constantly be doing that, and I'm sure many of us do that. Facilitating communication, it's a helping profession. We're helping people to communicate. So, given that interpreted encounters need at least twice as much time, misunderstandings can take twice as long or more to clear up, because communication breakdown compounds. When you put a sentence like that up, communication breakdown compounds, what the heck does that mean? I decided to leave that in the presentation because it's demonstrative of how ambiguous language, can lead to something. Well, what does that mean? What's modifying and what's the verb and what's the adjective? Anyway, so the overarching thing is the point that I want to make is we should take this authority to be the facilitators of communication actively, to go in and correct what is getting off tangent, and really help guide people to communicate better, because not only are we the experts, but we really shouldn't leave it to patients and providers to have this responsibility. They already have enough of it, they will take it on themselves, and in a multilingual, multicultural encounter, they are not qualified to do this work. We are the only ones qualified. We are the experts in the room. We should hold ourselves to that standard. So, about personal bias and professional judgment, we all have biases, and They're unavoidable in communication. Has everybody our trainings probably go over that at times. So my first bias is to good communication, and that's what I call an explicit bias, in the sense that I know it and I can speak it out. So implicit and explicit bias, this is kind of the fault line around which things are clarified. Implicit biases are the biases that are not spoken, that are not formed. It's a bias that you might have that you did not think about. And it's important to make your implicit biases explicit. Now, maybe you're not going to tell the provider, oh, I have this bias, but if you recognize it within yourself, you can then adjust for it. So, know the assumptions that you're making. And you might not know them all right away, but let's take a good example, right? Let's say the provider says to me, I want to call my patient Alicia. What's an assumption I'm going to make there?
Yeah.
She, exactly. Alicia's woman. Okay. So one of my languages is Spanish. And Spanish is a gendered language. Many of us speak languages where you have to choose gender. That's just how the language works, So you have to make assumptions. And sometimes it's good to make assumptions. Sometimes, as an interpreter, as someone who, comes across people day in, day out, like, you will make assumptions, and most of the time, they're going to be good assumptions. As long as you know what assumptions you're making, and as long as you are ready to discard them at a moment's notice. Guess what? Alicia uses he, him pronouns. So when I get on the phone with him, I'm going to call him he, him, and he is going to be him for all of himmery. and that's just how it goes, And as long as you can direct yourself to do that, I think you'll be all right. Now, when it comes to professional judgment about changing, the mode you are in, going from conduit, clarifier, broker, advocate, that kind of a thing, there are some questions you can ask yourself. Is what I'm about to do in the interest of better communication? As I say, that's my North Star. One of the things I would say about this also is, if you feel like something is not right, it probably isn't. You may not know exactly what to do about it, but chances are that you do need to do something other than continue in the vein of the conduit. And it will come to you with time. I'm sure, these are the things that you learn through practice. Is anybody here better positioned than me to speak to the problem? If the patient is not understanding how a medical procedure works, and you do have an understanding of it, do you explain that to them if they're having trouble, or do you tell the provider, I'll explain it to them, or do you go to the provider and say, the patient is not understanding? I think there's a judgment call of that, but I think the provider is generally best positioned to explain it, at least to give guidance, Maybe they speak again and they use a lot of technical terms and you're like, well, okay, this is going to go on for a while if I don't kind of smooth this out a bit. So you put your own, you put it in words that a patient can understand. But, do think about whether the provider might, or if a patient said something and the provider didn't understand it, give the patient another chance to say it in their voice because they know best. Is it necessary that I insert myself this way? So, necessary that you insert yourself. The question, the emphasis is on this way, should I be advocating or culturally appropriate? Could I do this a different way? These encounters happen at the speed of speech, so they're happening very quickly. You won't always know right away which intervention is the best to do. That's okay. You're going to make mistakes sometimes. You can correct yourself. But it's good to keep this question in the back of your mind. What are the pitfalls that could occur? Another good question to ask yourself. It's all about striking a balance. That's my word, balance is, instead of impartiality and neutrality, I go with balance. I like the analogy of a tightrope walker because, 1 minute you've got your balance and the next minute you kind of, whoa, you gotta get it back. And that's often how it is. Things go off the rails very quickly. So, as I was saying before, don't be afraid to correct yourself. I've learned to do it all the time. I've learned to become more open in my profession to just, I would like to clarify something, provided something that I said before, I may not have gotten it right. Correction, I think, is very important because it's part of making things more, started making things more correct. That's a bit of a tautology. Let me move on. Here's another thing. Accepting guidance and correction eagerly. Oh, goodness. Oh, I've got stories to tell about that. Eagerly, I use that, I picked that word very deliberately. Eagerly, thank you for correcting me. When the correction is appropriate, when it is correct to be corrected. Someone says, yeah, I didn't say that, I said this. Okay, I was once on a unit with, a psych unit with a patient who was saying a lot. So I went into simultaneous mode. There was no way I was going to consecutive with her. There was a provider I was interpreting in English for, and a social worker who spoke the patient's language. And a few times, as I was interpreting, the social worker said, no, she did not say this, she said that. No, she did not mean this, she meant that. I could have gotten catchy about that, perhaps. But it's not about my ego, it's about facilitation and communication, and the social worker was absolutely right. She corrected me correctly on all counts. And frankly, I was so busy trying to keep up with the speech that it was no wonder I was going to make a few mistakes. So I took that social worker aside and I said, thank you. I'm so glad you were there. You helped. And sometimes I'll even do that with family members who are a little overeager to be in our spot. Okay, as long as there's a sense that the communication is able to go forward, even if it's a little choppy and a little weird, it's good that they're there. It's when the communication gets out of balance, that's where we get the authority to intervene and say, hang on a moment, we need to get things, on a smoother road here. So be adaptable to the situation. Here's where I want to talk about being adaptable. I want to talk about speaking in the first person for a moment. I will speak in the first person. You want the provider to address the patient directly. The patient should address the provider. And then the provider says, tell him that, and the patient says, bien, dígale a la doctora que, or tell the doctor that, right? And it's this sort of, and I've heard some interpreters say, well, please address the patient directly, and I find that, maybe I'll do this once, but even then, I don't want to put more of a communicative load on people who already have a lot going on. And if I understand what they're saying, even if they use third person, I'll just interpret in the first person anyway. Tell the doctor that okay, well, we can tell the doctor that off and then start with the I. We're good, The one place I would say that this can be is where you have, let's say, a patient and a family member, same gender or something like that, gendered language, and the patient went home and his son got his medicines, tried to get his medicines, but he couldn't get them, and now he doesn't have the medicines. Well, who doesn't have the medicines? The son or the patient? This is where I will say to a provider, please address the patient as you, so that we can differentiate. And a provider is much more likely to be receptive to it, because there is a palpable reason. Pull back the curtain. What I mean by this is, there's a certain thing that we do when we're going cross-cultural and cross-linguistic that patients and providers might not know about, are likely not to know about. It can be good to let people in on what you've done, what I'm doing. For example, explaining starch to Haitians. What do I mean when I say, how do you translate starch? There is a word we can use in Haitian Creole for starch that nobody who didn't go to college is going to know. So I use the word flour, F-L-O-U-R. I use vegetables that are flour. For example, starchy vegetables, this sort of thing. And I might tell a diabetes educator, I use this term because this is how I know my patient will understand it. The diabetes educator is often like, I never thought about that. That's really cool. Thank you for telling me. It can really enhance people's cultural competency, if you sort of give them an in on what you might be doing sometimes to facilitate communication. Don't be afraid to give guidance about it. Don't be afraid to say to a provider, from what the patient is saying to me, it appears to me like this approach might be better than that approach, for example, or something like that. Or, in my culture or in the patient's culture, doctors tend to take this approach to something. You're the expert in communication in the room. Nobody else is going to do this but you. It is on you. It's part of what we do. I profoundly feel that. Don't take things personally. Oh, people have their bad days and they take it out on the interpreter. It's tough, you know. As I say, my North Star is, am I facilitating communication? I had an encounter once with a provider who was being such an irascible curmudgeon. He wanted this patient to do this procedure. He threw a consent form in her face, did not explain it, had her sign it. She signed it before I could get a word in. I went back, and I said to him, could I get the consent form so I can sight translate what's on it? He said no. I was astounded, and I had to calm down after that. And I told my supervisor, I said I need to get something off my chest. I wrote a big email. I filed a report through the SIRS system, which at our institution is how you can report safety events. It was just awful, and the provider was so rude. And then I said to my supervisor, I said, if that provider needs an interpreter again, send me. Send me. Because somebody ought to be in that room who has the patient's interest at heart. And that's where the advocate role comes in. Because sometimes, most of the time, you are going to be the interpreter. There may be these few times where you can't do what we normally think of as interpreting work. You have to navigate a minefield of, somebody is just losing it. And if your presence there can help the situation go forward, you should be there to the extent that you can be, to the extent that you feel you are able to contribute. And maybe maybe you have to excuse yourself. That's something you can do as well. But don't shrink away, just because somebody else might be having a bad day or not doing things the way you want. It doesn't mean anything is your fault. It's their bad day. And you're just there to do your job, and it'll be over with, and you'll move on. Don't take things personally. Come from a place of compassion. I get the feeling that most of us do that. This is intimate stuff. Patients' life details, illnesses, cancers. Am I going to be able to have children, doctor? It's really intimate stuff, and providers are dealing with that and having to hold it, and many of them understanding they don't have the time or the space to really fully receive a patient the way they would receive someone in their family going through something like that. So when you're in the space, you can kind of add that compassionate approach to things, and as I said, it's a balancing act. Compassion is not giving the patient a ride to wherever with you, necessarily, but that's a judgment call you'll make in terms of what the balance of things are. It's something that we learn as we go, because good interpreting is an art. I want to say this because I think that a lot of the things that structure our professions are very science-based. The science says this, the science says that. The studies say that the interpreter does the best job when they stay in their interpreter role, they don't go outside their lane. And that's very good guidance, but what we do is just like what providers do. You don't know what's going to happen. You don't know how someone's going to take something. It's a constant. That's why I love the tightrope, because it's a constant balancing act. We are artists in a sense. We are doing an art, and we should remember to think of it that way. In that vein, I think that we can have more confidence to bring forth our expertise, and not feel like we're limited by what we can't do, but remember, in essence, what we can do. Now, I would like for providers to look forward to using us. I think that if we position ourselves as facilitators of communication and take that more artistic role, providers are more likely to see us as partners. There are the providers, we all know about the providers who are kind of like, well, if I can get away with not using an interpreter, or, well, do I have to use one? Maybe I'll only use one for the consent. I want situations where providers are like, yes, I'm so glad you're here. I need you. You're my partner, my comrade, my co-provider in getting what this patient needs. And I think also, I didn't put this in here, but I think that when we step more into that role and find ourselves more open to seeing ourselves that way, it makes it better for us. You know, it's healthier, it's more of a human-to-human engagement. I know we're going to have in the plenary a presentation about AI. I don't think AI is going to replace interpreting anytime soon, and this is why. This is what we can do, this compassionate approach, you know, and the human to human. This is the kind of thing that we can do, that we will be doing, that AI will not do anytime soon. And I don't know, I can't see it happening in my lifetime. There's nothing like human to human connection. So that is pretty much the breadth of my presentation. I wanted to leave a couple of resources here that I found very instructive, very incredibly informative. You know, from where I got my a lot of the background to what I've been saying. This book, Medical Interpreting and Cross-Cultural Communication. Claudia Angelelli was somebody who kind of broke open the idea that the interpreter should be invisible. That used to be a thing in our profession. We are invisible. You know, and she was like, no, we are not, and we shouldn't be. And my gosh, her book has so many examples of that. And then the demand control schema. I want to put out a word for the ASL community, because the demand control schema comes straight out of the American Sign Language community and the experiences they've had. Oh, goodness. You all are so far ahead. And this is just all of the ways in which communication happens, is affected, is broken down, the different things an interpreter can do, the different loads that interpreters and other participants carry. This book is indispensable. I'm so glad I have a copy of it. That's pretty much all I have to say. I guess for the rest of the time we can do question and answer. All right. Yeah.
So, first thing I want to say is that your talk for me was really validating, because you were talking about things that I experience every day, and the fact that you're up there talking about them is telling me that I'm not the only person this happens to. There were a couple of things that you touched on that are kind of pet peeves of mine, and I wanted to. You did talk about them already, but I wanted to. The first one you did talk about, the 17th time. The second one you didn't quite so much. But the first one is the first person. And because I get really annoyed by it, right? And I think we all do. And in the community that I work with, which is Spanish speakers, the vast majority of my patients have been here for some time. And it's not that they have no English. It's that they want an interpreter for the medical language. They want to make certain that they know what the provider is saying. So when providers talking to me, it happens with every patient. When they talk to me instead of the patient, they're excluding the patient from the conversation. I don't know if the patient knows English or not when I walk into that conversation. But when the provider does that, I always tell the provider, you're excluding the patient. They can probably understand me. It happened to me this week, in fact, that the patient heard me say that and started responding in English to the things that the provider was saying. Like you, if the provider switches back into the third person, I usually won't bring it up a second time. I certainly won't bring it up a third time. But I do always try to bring it up on the first instance. The other pet peeve is that a lot of the providers that I work with seem to think that my name is interpreter.
My name is interpreter.
Whenever I begin a conversation, I work with most of our work on the phone. Sometimes we do go in person. And when I go in person, it's not a problem because they're going to read my badge and they're going to yell at me the way that my mother did, because you read my normal name as opposed to the name that I actually use. But that's the one that's not bad. But when I'm on the phone, I always introduce myself. I always say, my name's Andy, I'm going to be the interpreter. And some of the providers are really good about it, and will use my name throughout the conversation. Some of them will
not even acknowledge that I exist. I will introduce myself to them. Let's say you're in the room with the patient, if you want to introduce yourself. And that's it. So I was just wondering if you could touch on those two things. Okay. Was that not questions? Is it rather a statement?
I don't know, I give my thoughts. I totally agree, I guess. I mean, the whole first person thing, I agree with you that it's not in every encounter that I would stop myself from saying to the provider, like, please address the patient. I've done that before. I agree with you, our patients are not stupid. You know, even when they don't speak a lot of English, if they've been here a while, like, they can kind of tell. Even if they haven't been here a while, people kind of see when respect is happening or not. That lack of respect can lead to lack of trust, so it's definitely a communication building thing to redirect people. Did I?
No,
Yeah.
that's very helpful.
Sure. Let's see. Is that Lisa?
Yeah.
Yeah.
Two things. One is that I think everybody should be talking about working with an interpreter rather than using
Working with an interpreter instead of using an interpreter.
Exactly, I think so.
Can you go closer to the mic?
I don't know how you institutionalize that concept, but it's needed. The other thing is, I wanted to mention that in interpreting studies, there's a line of people who argue that communication is as much about words as it is about interaction. You know, it's known that about 80% of communication is nonverbal. And there's rich literature on how interaction affects communication. The most famous book is called that Communication as Interaction by Cecilia Medensko, but she's been used a lot by students of interpreting in social linguistics since then. That's something that we should include.
Thank you. I saw some hands in the back. Let's see. What's your name? Yeah. Yeah. All right.
I'm Abigail Hubert. I've been working in ophthalmology as the interpreter in Providence, Rhode Island. Is anyone else from Rhode Island? No. Yeah. I'm so sad that there. Anyway, that's relevant to my point. There aren't too many Rhode Island interpreters who participate in the conference and get more further training opportunities. So I wanted to just point out that I think this is a wonderful presentation, but probably a little advanced for some of my coworkers. I've noticed some of them maybe haven't gotten used to trying out being a conduit and are sort of interfering kind of at basic levels. So I think it's a wonderful presentation, but maybe it's maybe more for intermediate interpreters. And I just wanted to add, I think the idea about assumptions is really important to think about what assumptions we're making, including when you mentioned that sometimes there's time constraints and you have to help get things moving or something like that. And I think it's important to think about how we're there for the doctor and for the patient, and they might not have the same goal. So maybe the chief complaint in the system is not the patient's being questioned, and maybe the patient really wants to say something, and it might not be what the doctor wants to hear, but maybe it's important for the patient to say it. So it is interesting to think about, is it time for the interpreter to help, or is it time to let the patient or doctor, maybe let the patient keep talking?
Thank you. Saw a hand in the back, way back.
Hi, Michael. My name is Frank. I am not a CMI, and I lack your experience. One thing you and I do have in common is, at least we present as white males. And a thought I had, and this might not be a question that you can answer. It might just be a more rhetorical question, but all these, it was a fascinating presentation today, achieving the balance, all these suggestions you had. Don't be afraid to correct yourself. The be adaptable, pull back the curtain, don't be afraid to give guidance, all these great ideas. A thought I had, something I was wondering was, I feel like in the community interpreting I've done in the past, my own, for Mandarin, given that I am myself often in the privileged position of being a white male, gives me more leeway and ability to interject and do a lot of those things. So my question was, and it's kind of just thought, are these things harder to do if you're not a white male in a position of power? And so, yeah, I'm here to listen and answer.
You're asking the wrong presenter. Let's see. There was a couple of hands over here, right?
I just wanted to answer to that.
Yeah, please.
One comment is, I've worked in the same place for 7 years, and I know a lot of providers, and I know a lot of the desk people, and they respect me, and they respect I've been careful and I've earned that respect, and I think some things like that take time. And that also comes from kind of a New Englander point of view, because things take time with us to get to know people, and things happen slowly, not quickly. So anyway, that's just that I feel the same freedom you do. That I make certain judgments and keep the balance within certain limitations, knowing my standards of practice and my role.
Mm-hmm. Sure.
Isn't there someone else further back? Oh, I'll continue next time.
I just thought I would add to what you were saying in terms of, I pretty much agree with everything that you said in terms of what interpreters ought to do. But if I were going to explain a word, I would be absolutely sure that I told both people how I would like to explain it and make sure that the person who said it in the first place agrees that the way I'm going to explain it matches the meaning that they had in mind before I go and say it myself. And then, I know I don't have to do this, but you know that nice triangle chart that you put up there?
Yeah.
Do you know the author?
Do I know the origin of it?
The origin, yes. Do you know who is the author?
The
She's
author.
right here.
Yeah.
Can I embarrass you by asking you to stand? She's still embarrassed, but Cindy wrote after that, 40 something years ago. Was it 40? 30? I don't know, a long time ago, before there was a national council and we were still meeting to think about creating something that later turned into being the National Council on Interpreting Healthcare. And out of all of these discussions of what do interpreters do and what should we be doing, that was what came out.
Awesome.
Thank you.
Oh, okay, yeah, and then,
Hi, my name is Ines. Just a comment that the first person made about not knowing if the patient speaks or understands English. I run into that a lot, and then I just found it more easy to ask the patient at the beginning of the conversation. Do you understand any English, a little bit of English, a lot of English? Because they do want to hear it in their language, because they don't want to miss anything. And so it just makes it simpler. And so that way, if they answer a question in English, then I know that I can go beyond unless they have that glossy
over here, as you come to the person who had a question, I just want to say, I remember one encounter I had in which the provider told me, I've had many sessions with this patient. She understands English, does not need you to interpret my English into Spanish, but prefers to express herself in Spanish. So with your blessing, just interpret what she says to me. And that's what I did. I did not interpret the English into Spanish. That's, the guidance, facilitating communication, etc. I think, And yeah, sometimes a patient may have preferences of this sort that's sort of like, okay, I do need you here. There may be certain questions that I understand and can respond to right away or something like that. And I try to go with the flow and just check in, okay, we're getting understanding. Good. I think that. So, did you want to ask a question?
Yes. So, first of all, thank you about talking about Dr. Dee's work. I love her work, and I think every single interpreter should know the man control schema. And my question is, when you were talking about the pyramid, you were talking about switching roles, right? Is that your preference, use that term of like switching roles, or is it because you're talking like the lingo that the community knows? Or would you rather use like a different term for it, like perhaps like changing tasks versus changing roles? Because Dr. D talks about that as well, that for her it's problematic when interpreters say I'm switching roles because you're still an interpreter. You're just doing a different task. Like when doctors are in consult and they're talking to their patients about their medical care, they're doctors, and sometimes they have to address like other things that are not medical. And they're still doctors. They're not saying, oh, now I'm stepping in the role of a social worker, right? So that's just my question. Do you think we should come up with a better term or a better way of saying this?
Honestly, I did not think about that. The word role is widely used. I'm quite open to it. It sounds good to me.
You don't announce when you're going to switch roles. That happens here.
Yeah.
Is it a verbal, articulation of good? Now I'm going to advocate.
You mean, do I recommend we say that to providers?
No, yours, and if you suggest that we have to announce when we're switching roles.
No, actually. What I was getting at was that there are some interpreters who will announce it, who will say, they won't say, I'm switching roles, but they might say, the interpreter would like to clarify something that the patient has said. I especially find this on the phone, and it's sort of, I think it's fine to say, I'd like to clarify something, but not make a big thing of it, yeah.
Hi, is the developer of that?
Yes.
My blessing to this change in language. I love it. How am I going to think about that back in 1995 or whatever it was? No, I love that idea because the whole purpose of this was, at the time in the early 1990s, the only training for interpreters was for court interpreters. And the role of the interpreter was render in one language what was said in the other. If nobody understands it, it's not your problem. And as somebody who was coming out of both a social justice background and a background of working with rural people in Latin America for many, many years, I said, this is not going to work in healthcare. This is not going to work because there'll be misunderstanding, and misunderstanding can be deadly. So the role of the interpreter in healthcare has to be different. It has to be, and what we would say in Bridging the Gap is, facilitating understanding and communication between people speaking different languages. And that's an active role, not a passive role. It's an active role to facilitate understanding and communication. And our problem at the time was we had a lot of people coming into community interpreting who were coming in there not out of a love of language, but of a love of the community. They were coming because they wanted to be of service to their communities. And as a result, there was a real social worker mentality. A lot of interpreters, remember, no code of ethics, no standards of practice at the time. No training available either. People wanting very much to help. They wanted to help the patients. And a lot of times they were taking over the role of social worker or many other roles of other people in the healthcare setting. And so it was getting to the point that everybody in the hospital just said, oh, that person speaks a language other than English, the interpreter will just take care of everything. And they weren't doing their jobs like they would do for an English speaker, for the non-English speakers. Does that make sense? Because the interpreter's gonna take care of it. And so there needed to be some kind of a structure where we can say, okay, what is our purpose? To facilitate communication. Anything that's outside of that is really outside of our role. But facilitating understanding and communication isn't just being a conduit. It's exactly what you said. It's not being a bilingual parent. There are other things that come into it. There's misunderstandings that take place because of linguistic problems, because of undiscussed cultural differences, and because of systemic issues. I suppose racism is one, certainly, but also just mistakes. You know, people are moving fast, they're making mistakes, and everybody needs to be willing to step up if they see a mistake. I don't care if you're the janitor, you step in if you're seeing a mistake that could hurt somebody. So the idea was to provide a structure for the role of the interpreter that would be flexible, that would allow taking on different, we said at the time, roles, as a means of fulfilling the purpose of the interpreter, which was to facilitate understanding and communication. However, I love this change in language. I'm gonna steal it. Can I steal it?
You can always steal from me.
I love it because it is, I do feel like when I stop conduit interpreting, when I step in to say, as the interpreter, I'm concerned this patient is not understanding, could we do a teach back? I don't feel I've stepped out of my interpreter role. I'm still facilitating understanding and communication. That's my purpose. I'm still doing that, but I have taken on a different task. So I hereby give my blessing. Let's change that. Thank you.
There's a hand up down here. How much time we got left? We're overtime?
Yeah. It's
Oh.
okay, we have a break now.
Can we afford a little time for you to say what you want to say? I don't know. I guess people can.
Alright, I just wanted to add to Natalie, Spanish interpreter and also an interpreting services manager. And as a Latina presenting at times culturally ambiguous looking person, I find it easy to see myself as a peer and make sure that I advocate to say, we are working with a provider or the provider's working with me. They're not using me, they might be using a language service that I can provide, but they're not being used. And this is something I've been working in healthcare since I was 14 years old. So I see myself as a peer, I saw myself as a peer then, and I see myself as a peer now, many years later. And I feel like it's a little bit hard as an administrator to kind of instill that same idea into other interpreters, to make sure that you do see yourself as a colleague of this doctor that has many years of medical school experience. But you as a native speaker, you as somebody that has studied the language extensively, you are also a professional. You have developed skills that this doctor does not have. But how can you convince somebody of that? I know you have some administrative background, so I was wondering if you have any insight. What can be done?
I do. All right, and I think we can wrap up on that if we're over time. But very briefly, I'm blessed to work in an organization, CHA, that supports its interpreters very well, especially at the Cambridge site where I work. Like I feel like when certain things have come up where there have been, ethical concerns, or where there, an interpreter has had to kind of do things that, that are a little bit more involved, more complex, and that kind of thing, that we get rewarded for that. And we are managed by people who come from our ranks, who know what we do, who understand what it's like in the trenches, and who have not just an acceptance, but an appreciation, for the doing of that work. And my supervisors there, first Vanessa and Norio, and now Norio, would kind of actively take what we would do, the things that, kind of very much go outside of the idea of what an interpreter should do, or something like for example, to call different providers, when a patient has referrals to different places. Okay, well, the patient's going to need to use an interpreter at some point. So why don't we do it right there? Because we just got out of the primary care appointment with the patient. So, we can do that. And when we took those initiatives, we were rewarded. So reward your staff for acting in ways that are proactive. I feel like that's I don't know, that's the first thing that comes to mind for me.
Thank you so much.